that yes, he said that most of the physicians are there. So that's why I've selected the topic, that approach to ILD, physician's perspective. So there is no confusion. I don't believe that ILD should be treated only by pulmonologists, because only 7,000 trained pulmonologists in this country are there, and they are not able to cope up with this burden of the ILD. So yes, MBBS, those who have been trained or sensitized for ILD management, MD medicine, we are already treating, and MD pulmonary medicine or PG pulmonary medicine, all are authorized to treat, to diagnose and treat ILD. So this is my disclaimer, that not only pulmonologists should treat, but when to treat and when to refer, as I used to mention, for any disease, we must know. So being pulmonologist, although there are 5 vital organs in the body, but we pulmonologists believe that we are very special, because we can live without food for 3 weeks. So most of the gastroenterologists now talking of food, what to take, what not to take. We can live without water for 3 days, but we cannot live without air for not more than 3 minutes. And we breathe around 25,000 times a day. And that's the beautiful one pair of lung that God has gifted to us. God has gifted so many organs in the body, but the beauty of this organ is that 100 square meter area, about 10,000 liter of blood and air passes day and night within 24 hours. And what is the net result of this ventilation and perfusion? The delivery of 500 liters of oxygen, which is required for our daily activities. So my agenda would be for next 20 minutes, may I get probably 5 minutes more. So introduction, epidemiology and Indian ILD patient profile, diagnosis, management and prevention. So introduction, what is ILD? It's a group of more than 200 diseases. So it's not a single disease, my dear friend. Distinct lung disorders that tend to be grouped together because they share clinical, radiological and pathological features. That is the only region. These disorders are sometimes also called parenchymal, diffuse parenchymal lung disease, DPLD, to make the point that interstitium is not the only component of the lung affected. So group of more than 200 diseases, underdiagnosed disease. So basically we have to explore more and more, and we have to do capacity building of our medical fraternity more and more, especially my GPs and my physicians, so that we can have early diagnosis of ILD and we can have better outcome of ILD. Everybody knows since our MBBS days, this is the normal interstitium, everybody knows, with alveolus surrounded by interstitium, capillary, endothelium, and everybody knows that there is an injury that ultimately causing the DPLD, that is the group of 200 diseases. And the injury depends on what? Any one trigger, that injury leads to inflammation, and inflammation leads to fibrosis. The question is how much inflammation and how much fibrosis, that basically depend out of the 200 which diseases he or she may develop. More inflammation, Dr. A.K. Singh or Dr. Surikant will happy, because it is easier to treat. More fibrosis, we are really, as you see, very scared. So repeated injury leads to the development of widespread inflammation and of fibrosis. And how much inflammation and how much fibrosis, that is the beauty of pathology and beauty of presentation and of course prognosis of the disease. So this is more inflammation, but this is more fibrosis. So two kind of spectrum can be: more inflammation, less fibrosis; more fibrosis, less inflammation. And this is the classical, you see, classification of these. That if etiology is, whether this etiology is unknown or known, and third category is still unclassified. If there is a known etiology for which you have to take the very vibrant history, very elative history, very detailed history. So this could be the hypersensitivity immunitis if the exposure is organic dust. This can be sarcoidosis, this can be connective tissue disorder, this can be exposure to the drugs or radiation or infection or occupational. So a lot of history is required to know the cause. Then there is an unknown type of pneumonias. Most important is the idiopathic pulmonary fibrosis, when we don't have anything other than fibrosis. Then NSIP, then cryptogenic, smoking related and lymphocytic interstitial pneumonia. So this again have been endorsed with some modification in our publication. This is national publication in Lung India 2020 July. I happen to be co-author in this, and you can read what is the updated classification, which we are following. Now, you need not to have the American data and US data. Now the time has come, believe me, the pulmonologist of the India, that we have brought the Indian data, and that data is now, you see, without this data, nobody can write a paper on ILD. Now I'm going to show you the power of the Indian pulmonology, that we have created so much data on Indian ILD, the most neglected and most, I would say, rare disease once upon a time it is called, that now if American publish a paper or European publish a paper, he has to read our paper, he has to cite our paper. So that is the power of, and these are the 4 important studies from India. One study that is called India ILD Registry, and this India ILD Registry published with the 1084 patient population. This is the largest ILD registry, not in India, not in Asia, but in the world. Have a grand round of applause for Indian pulmonology, that we have created this huge data and huge patient profile from India. The second study is the patient of 884. This is from our King George Medical University. Another study is from PGI Chandigarh, and another is from Patel Chest Institute. These are the 4 important studies, and out of the 4, fortunately, I happen to be co-author in largest 2 studies in this country. This is the India ILD Registry, published in American Journal of Respiratory and Critical Care Medicine on March 2017, 7 years, 8 years back. And my dear friend, this is again my proud privilege that I was the president of Indian Chest Society, under which manner this ILD India Registry published in American Journal. So what it shows, what is the profile of ILD? Before that, the whole European literature and American literature was full of that the idiopathic pulmonary fibrosis is roughly 50% or even more than 50%. But we showed the world, no, you are not correct. You don't have the time, you don't have the spectrum to decide. That is, hypersensitivity pneumonitis ILD is the most common, roughly 50%. And then, of course, we have connective tissue disorder, and then idiopathic pulmonary fibrosis only 13th in the place. So that changed the whole scenario. And then we have our own publication. And then what is the nutshell now we have from this study? So this slide is very careful to know the ILD patient profile in India. One is the prevalence. Estimated increase in ILD cases due to improved diagnostic. Number 1, they were the cases, although 10 years back, 20 years back, our teachers were used to say this is a rare disease. Now it's not a rare disease because we have improved our diagnostics, number 1. Affects primarily those more than 40 years, higher prevalence in males, higher symptom burden because of chronic cough, dyspnea, fatigue. So जैसे हर चमकती चीज सोना नहीं होती, ऐसे हर फूलती हुई सांस अब अस्थमा नहीं होती. Now remember this, because most of the ILD patients, they are taking either inhaler or they are on anti-tubercular treatment. This scenario we have to change. This is our more responsibility to do the capacity building of our own medical fraternity of our own people. Reduced physical function and quality of life, mortality rates, IPF is still, median survival rate is 3 to 5 years from diagnosis. Overall ILD mortality is 10 to 20% annually. So always explain the prognosis to begin with whenever you are dealing with a patient of ILD. That roughly 20%, every 5th patient of your ILD in your diagnostic fold will die within a year. Survival rates, poor survival rates in idiopathic pulmonary fibrosis type and better prognosis in non-fibrotic type. Hospitalization rates, yes, frequent hospitalization, exacerbation leading to hospitalization, and we have to address these exacerbations also. Significant contributed to the morbidity and mortality in this country. Pulmonary function decline, annual decline is 150 to 200 ml per year. That's very significant. Normal decline of lung function after 30 years of age is 20 to 30 ml per year, but this becomes 10 times. Decline in diffusion, that is called DLCO, is 3 to 5% per year. Comorbid conditions, pulmonary hypertension is the most common comorbid condition, 30 to 40% of ILD patients. Cardiovascular disease and diabetes, although common comorbid condition with ILD, and regional variation, higher prevalence in the southern India in comparison to the western India. Reasons we don't know. Differences due to environmental and genetic factors. So I think with these points, now I have not shown any slide what's happening in Canada, what's happening in Brazil, America, Europe. No, there is no need for that. You have the complete spectrum of ILD from our own people. So how do you diagnose? The 4 things on which your suspicion starts. So PG student, please concentrate yourself now. Stop your mobile and WhatsApp. If you want nearly tea is being served at showcase so that you can refresh. Dry cough, shortness of breath, distal clubbing and bilateral basal fine crepes on auscultation. If you are getting 4 things or 3 or 2 or even 1, even dry cough is the first symptom of any ILD. So my dear friends, be aware if the person is coughing for weeks together, months together or years together. Now what history? History is very important, but because of lack of time, so I will rush through. Connective tissue disorder, very important. So I think you have the rheumatology friends, orthopedic friend, and we have so many very good combination here. Dr. Nandini Rastogi is good enough that her husband is orthopedic surgeon. So she can ask, take the detailed history. So all these symptoms, the pain in peripheral ischial joint, morning stiffness, photosensitivity or rash, oral ulcers, Raynaud phenomena, all these things. And then occupational history, very important. Occupations in this country are widely different from the Western world. So we have to consider, we have to think of all our occupations. Choti cheezein, I used to say from bhatti to bhatta, lohar to sonar, so many occupations are there, and we have to explore coal workers and everyone. There are a lot of list is there, I will not, this is fishman picture, you can go to the fishman, all residents please take the picture and you can take the advantage of this reference which I have given, and you can find a lot of occupations are related with various ILD. Environmental history is also important, and very important history is the smoking. A smoker or ex-smoker, they have high burden of D, DIP, RILD, LCH and IPF, both. So all 4 are related with smoking also. Then a lot of things are environmental factors. Every factor, अक्सर मैं कहता हूँ घर को घर रहने दो, चिड़िया घर मत बनाओ. कुत्ता, बिल्ली, तोता, खरगोश, पता नहीं क्या क्या. भाई पहले ये सब होता था, लेकिन अलग होता था बाड़े में. अभी तो क्या है, बिटिया है, टेडी बियर की नींद नहीं आती. जितनी बड़ी बिटिया नहीं, उससे बड़ा वो टेडी बियर लेके सोती है. My God, what's happening? कुत्ते बेडरूम में. So a lot of drugs are also being implemented. That's complete list is there again in the Fishman. You can read this list. So family history is also important because most of the time it can be genetic also. So take detailed family history. So and then certain you see important symptoms are very particular. That pleuritic chest pain may suggest of connective tissue disease, pneumothorax, yes, indicating LAM or LCH. Very important. If pneumothorax, ILD presented with pneumothorax, think of only 2 ILD, LAM and LCH. Wheezing, hypersensitivity pneumonitis, very characteristic. That's why hypersensitivity pneumonitis most of the time they are being prescribed as inhaler, because sometimes usme ronkai bhi dukh jate hain thode. So hemoptysis, yes, every hemoptysis patient in this country is being prescribed as anti-tubercular treatment until proved otherwise. So, but hemoptysis can be feature of ALD. So, जैसे हर चमकती चीज सोना नहीं होती, वैसे हर फूलती हुई सांस अस्थमा नहीं होती, जैसे हर चमकती चीज सोना नहीं होती, वैसे हर खांसी का खून टीबी नहीं होती. आज बहुत चमकती चीजों से हम परिचय कराएंगे आपका. So, substernal chest pain, sarcoidosis, and systemic symptoms. You see, MD medicine is more competent and qualified to take the systemic history. I agree. I accept that we pulmonologists are very tubular in vision and we just forget to take the other symptoms. So I think if you are not having enough time, please have the MD medicine opinion also, and long list is there so that your MD medicine colleague, your physician colleagues, your rheumatology colleague, your orthopedist colleague, your ENT colleague, your ophthalmology colleague can have so many symptoms. Similarly, a lot of skin spasticity. So it's a multi-system disorder. It can go to the derma, it can go to the skin, it can go to the ophthalmology, it can go to the ENT, it can go to the physician, it can go to simply MBBS. So examination is also important after this history, and we know that classical is the Velcro crepes, the fine crepes, bilateral, basal. And then देखिए दो तरह से होता है, एक पर्दा नीचे से गिरता है ऊपर से नीचे और नीचे से ऊपर. तो ऊपर से नीचे गिरता है किस बीमारी में? सबसे ऊपर बीमारी कौन सी आती है यूजुअली? pulmonary tuberculosis. इसमें नीचे से यूजली, हालांकि इसमें भी कुछ है जो ऊपर से नीचे गिरते हैं, लेकिन इसमें पर्दा नीचे से ऊपर गिरता है. सबसे पहले लोअर जोन इन्वॉल्व होगा ILD. So don't forget the column, 50 to 60%, even more than that, 60%, maybe 70% people. मैं तो कहता हूं जो पेशेंट ATT और इनहेलर लेके आता हूं, मैं पूछता हूं डॉक्टर साहब ने आपकी उंगलियां देखी थी? नहीं साहब, सांस की बीमारी उंगलियां क्यों देखेंगे? तो मैं कुछ कहता नहीं, मैं समझ जाता हूं. So here not the seen that. So that's why the MBBS training, basic training is very important. Don't forget to do general examination. Then of course the so many other symptoms, for example malar rash, so many UC Grotton's papules, heliotrope rash, they are all suggestive of different kind of etiology behind this ILD, including Raynaud phenomenon. Chest X-ray, yes, chest X-ray is the basic thing about any respiratory disease, and it may show, yes, although not early changes, but see the chest X-ray, divide here, see the upper zone, see the lower zone, and you will have the cleanser diagnosis. Lower zones are hazy. You can have sometimes the upper zone and lower zone distribution also, but primarily ILD is basically lower zone disease. You can have reticulonodular pattern in the X-ray. On the basal, you can have nodal pattern, you can have reticular pattern, because chest radiology is a separate topic for understanding the ILD, so I will not go into the detail. Linear shadows you can get, and HRCT is the diagnostic. So revolution has been done in the diagnosis of ILD with the HRCT thorax. So this is the investigation of choice now, high resolution CT scan, and we have the UIP pattern is a very sacrosanctum diagnostic pattern for the idiopathic pulmonary fibrosis. The 5 components: honeycombing, reticular pattern, tractional bronchiectasis, architectural distortion, and subpleural or basal prominence. They are the most of the time you can see madhumakhi ka chatta, honeycombing. So this is all, it's a later stages you will find. And then NSIP pattern, that's second most common you will find. So there is no honeycombing, reticular opacities are there, tractional opacities, ground glass is there. So that's a different story in NSIP. Fibrosing versus non-fibrosing. More fibrosis, more honeycombing, more favorable of the IPF and worse prognosis. So tractional bronchiectasis you can see in fibrotic pattern, honeycombing you can see, and you can see the reticular architectural distortion. And this is the of course the algorithm which we have published again in the Lung India 2020, but I have you see modified for physicians. Only, can you believe, only yesterday night I modified this. I'm not satisfied with this, so I modified. This is my personal way of, you see, interacting with basically younger people. That to be done in all patients. What is to be done in all patients? History and clinical examination, radiological imaging, maybe chest X-ray, maybe HRCT, and pulmonary function. These are the essential for all. And as per the clinician's judgment, you may go for the serological investigation, bronchoscopy and BAL, and only rarely you may require the histopathological diagnosis. So this is the, I think this is my way of my personalized algorithm, and you can take from the from your very busy practice. Yes, I know 10 minutes or more, so don't harass me. So investigations. So this is the complete list of serological profile you can do. If your patient is having well-to-do, I say before advising the investigator, see the pocket of the patient. ऐसा ना हो कि जांच कराते करते मरीज आखिर में कहे सब आप दवा के लिए तो पैसे ही नहीं बचे. So the good doctors always assess the pocket before prescribing any prescription or any investigation. So indicated in all patients, yes, academically you are right, however done as per clinician judgment in a limited resource setting. So lung function, yes, lung function is very important diagnostic tool for obstructive as well as the restrictive lung disease. So this is the restrictive lung pattern you can see here. This is the small tidal volume, small expiratory volume and inspiratory volume. And 5 things to be done in lung function, not only one thing. The spirometry, the basic thing, lung volume, diffusion study, 6-minute walk test, and arterial blood gas. So if you don't, I think Dr. A.K. Singh generally practicing all these, and most of our chest physician colleague in Kanpur. So you also, you just refer to them, they will do all 5. Bronchoscopy, again the post chest physician prerogative, and there are certain indication where you can forward the patient to the bronchoscopist. BAL you can do, and BAL eosinophilia indicate other diseases, lymphocytes suggest different diseases. This is the interpretation and prerogative of the pulmonologist. Lung biopsy is very rarely, I mentioned it to begin with, very rarely indicated for unclear diagnosis after non-invasive methods. And two slides for post-COVID pulmonary fibrosis. You see, my dear friend, I started the post-COVID clinic on 5th July 2021. Can you see what happened to this post-COVID clinic? I'm still running this clinic. Because post-COVID people is still coming to my department, at least in psychiatry department, and that's we have a close collaboration with psychiatry department also. Two departments are still attended by post-COVID fibrosis. And my dear friends, we have developed the post-COVID fibrosis diagnosis and management also. This publication is done is Indian Journal of Chest Disease and Allied Sciences 2020. Unfortunately, I was also co-author, so you can go through the basically expert management of post-COVID pulmonary fibrosis also. And so these are some classical pictures of post-COVID pulmonary fibrosis which you can still see, and just take the history of COVID also. So this is the multidisciplinary, everybody say multidisciplinary, but as a MBBS you are already multidisciplinary. Who MBBS can say that I don't know rheumatology? Who MBBS can say that I don't know pulmonology? Who MBBS can say that I don't know radiology? So MBBS doctor is himself is an institution for multidisciplinary, and he should be the first point of contact at which the diagnosis should be suspected and proper referral should be done. So again, this is the ILD differential diagnosis. I can say that exposure related, connective tissue related, sarcoidosis, and then other rare diseases, and then idiopathic pneumonia. So these are the 4 or 5 groups. But there are non-ILD differential diagnosis also. ऐसा नहीं है कि हर सूखी खांसी और हर फूलती हुई सांस, हर क्लबिंग और हर वेल्क्रो क्रैप जो है वो ILD ही निकलेगा. So उसमें भी आपको you have to rule out certain cardiovascular diseases, for example congestive failure and pulmonary hypertension. Certain infectious diseases, important is the pulmonary tuberculosis, obstructive lung disease, asthma and COPD, certain lung cancer, certain pulmonary vascular diseases, certain drug induced diseases, and miscellaneous causes. So always remember the differential diagnosis. The most commonest mistake in the diagnosis of ILD, I'm not blaming anybody, even Dr. Surikant could make the mistakes, anybody can make the mistake. So 2 important differential diagnoses I have selected for you. One is ILD misdiagnosed as pulmonary tuberculosis, second is misdiagnosed as asthma. Because whatever the prescription pattern, prescription audited we are doing, we are getting the inhaler prescription for the ILD, we are getting ATT prescription. So this is the classical picture of pulmonary tuberculosis, this is sarcoidosis, and this is chronic HP. So just imagine the chest picture, but what is the difference between ILD and pulmonary tuberculosis? Fever is unusual. Fever is the classic recipe of the pulmonary tuberculosis. Hemoptysis is rare. I say until alveolar hemorrhage there is no fever in ILD, but most of the time. But abrief hemoptysis is not pulmonary tuberculosis, it may be something else also. Generalized X-ray shows reticulations here, usually upper zone affliction, but even pulmonary tuberculosis, especially in diabetics, can be involvement of middle and lower zone. Changes in nail morphology. Yes, nail morphology is usually not altered until there is a chronic fibrotic or chronic empyema where clubbing can be present. And sputum examination is negative while it is predictive. So sputum for CVNet had changed the confidence on the diagnosis of pulmonary tuberculosis. Now another differentiation between ILD and bronchial asthma. Yes, there is a difficulty in breathing here also, but asthma is usually history go back to childhood. 80% of asthma start from bachpan, and usually ILD you will take in the age of bachpan. 40 से शुरू होगी लेकिन आपके स्पेशलिस्ट के आते आते उसी में पहुंच जाएगी. So you can differentiate very. कब शुरू हुई प्रॉब्लम? बचपन से तो अस्थमा है, 40 के बाद तो ILD है. Difficulty in breathing is progressively and not episodic. It is always episodic in case of asthma while it is progressive. Changes in nail morphology called clubbing, here no clubbing. CT finding in general display, chest X-ray and CT scan are normal in asthma except in complicated situation like ABPA or something else. So normal chest, normal X-ray, chronic respiratory dyspnea. What is our diagnosis, dear friend, DNB students and MD student? Normal X-ray, normal CT, normal chest, and dyspnea. What is your diagnosis? Okay. Abnormal chest X-ray, abnormal CT, and chronic dyspnea. What is their diagnosis? But it can be some other also. चलिए पढ़ते हैं. So 3 X-ray. Chronic dyspnea. What is diagnosis? PG student. Asthma. Very good. ताली अपने लिए बजाओ. What is diagnosis? COPD. Lung. काले लंग ज्यादा दिखे, diaphragm flattened दिखे, air pollute, लंग हार्ट को बीच में पीस के रख दिया, दबा के रख दिया, ट्यूबुलर हो गया बेचारा. और देखिए हाइपर इन्फ्लेशन बहुत ज्यादा दिखे. तो सांस फूल नहीं नॉर्मल लंग क्या है? सांस फूल नहीं बढ़ा हुआ लंग क्या है? और सांस फूल नहीं छोटा हो गया, सिकुड़ गया लंग क्या है? बस हो गए. डीएनबी पास कर दें. आवाजी भाई अशोक हमें बुलाओगे, हम तो कह देंगे हम तो पहले पास कर चुके. सो दिस इज bronchial asthma, this is COPD, and this is ILD. So no confusion. Now treatment, last. So yes, we have again given the 2 types of consensus statement. One is published in 2009 in Indian Journal of Chest Disease and Allied Sciences, another published in Lung India. And in both, the story is same. So question is when to treat and when not to treat. You see the time has come when the doctors should say, now treatment is not required. गंगा जल और तुलसी दल कितने डॉक्टर प्रिस्क्राइब करते हैं? हाथ उठाएं. आज उठा ही दो. हम तो करते हैं गंगा जल और तुलसी दल या आबे जमजम. कोई करता है? हम तो करते हैं भाई. अभी कल रात को 10 बजे मैं तो निकल रहा था, कभी भी घुस जाता हूं वार्ड में, तो मैंने 3 की ब्रोंकोस्कोपी लगी हुई थी. मैंने कहा क्यों? लंग कैंसर वार्ड का राउंड लिया. मैंने कहा इनका परफॉर्मेंस स्टेटस क्या है? बोले साहब 3. तो मैंने कहा 2 के बाद तो कोई ट्रीटमेंट ही नहीं है, न सर्जरी, रेडियोथेरेपी, कीमोथेरेपी, क्यों करोगे ब्रोंकोस्कोपी? अब कोई आंसर नहीं रेजिडेंट के पास. मास दिख रहा है तो डालने का मौका मिलेगा, ब्रोंकोस्कोप प्रैक्टिस होगी तो कर दो ब्रोंकोस्कोपी. ऐसा बिल्कुल नहीं है. आई स्टॉप. मैंने कहा नहीं, कोई जरूरत नहीं ब्रोंकोस्कोपी की. When your investigation is not leading any new treatment or any policy treatment, please don't investigate the patient. When your treatment is harming to the patient, please don't treat the patient. इसीलिए कहा जाता था कि भैया प्राण निकले तो घर परिवार वालों के साथ निकले, लेकिन हम तो तुले हुए हैं, निकले तो वेंटिलेटर के साथ निकले. हमें कोई जरूरत नहीं है. हम तो मस्त है, बाहर खड़े हैं, वेंटिलेटर देखेगा, जला देगा तो ठीक है, मार देगा तो ठीक है. अरे भाई वेंटिलेटर का आउटकम कितना है? 10 से 15%. बस. कुछ गलत नहीं बोल गए? ज्यादा कम बोल गए क्या? ठीक है. So if you have to assess whether benefit is there or risk is there, पूरा हनीकॉम्बिंग पड़ेगा. कौन सा निंटेडेनेब क्या कर लेगा, परफेरियन क्या करेगा आपका ट्रीटमेंट? हनीकॉम्बिंग हो गई भाई, अब मत ट्रीट करो, अब सब हार्म करेगा, लिवर चला जाएगा, किडनी चला जाएगा. So you have to see whether benefit more or adverse effects are more. So the treatment is of 2 types, target the biology and target the symptoms. So disease modifying, they improve the health as well as illness, and symptom modifying, only 2 types of treatment. So palliative care can be given, pulmonary rehabilitation can be done. So this is the very simple. I have made this slide from all these things. मुझे जब बहुत अपने पे गुस्सा आता है कि मैं इतना खराब मास्टर क्यों हो गया हूं, तो किसी रात को मैं बैठ जाता हूं और ऐसे ही एल्गोरिथम तैयार करता हूं. दिस इज वन ऑफ देम. सो ओनली 3 टाइप ऑफ सिचुएशन इन ILD. 200 को 3 में. बस भाई 1 मिनट उधार दे दो. चेयरपर्सन ठीक, लास्ट है ये बहुत इंपॉर्टेंट. सॉरी. IPF ILD है, दोनों में ट्रीटमेंट है, फार्माकोलॉजिकल एंड नॉन फार्माकोलॉजिकल. फाइब्रोजिंग ILD है, एक सेकेंड कैटेगरी है IPF के अंदर, नॉन IPF के अंदर, फाइब्रोजिंग एंड नॉन फाइब्रोजिंग. इसमें आप एंटी फाइब्रोटिक दे सकते हैं. यस, निंटेडेनेब एंड परफेरियन, जैसे मैंने कहा हनीकॉम्बिंग जब तक ज्यादा नहीं हो जाती. सिम्टोमेटिक ट्रीटमेंट देंगे. कॉर्टिकोस्टेरॉइड ड्यूरिंग एक्सरवेशंस ओनली. corticosteroid exacerbations, corticosteroids during exacerbations. आप देखिए किसी में रेगुलर corticosteroid नहीं लिखा हुआ है. 5 to 10 days of oral corticosteroids during the exacerbation is allowed. Corticosteroid is not the treatment of at least fibrosing ILD and IPF ILD. Yes, if your rheumatology colleague is continuing, you can continue. So non-pharmacological treatment is also equal to the pharmacological treatment. Smoking cessation, vaccination and pulmonary rehabilitation, same. So So all non-pharmacological treatment is also important, equally important rather I would say. So this is about the pulmonary rehabilitation, and you should advise it, and this is our pulmonary rehabilitation team. This is our UP first in public sector. We have established pulmonary rehabilitation center at our King George Medical University. Lung transplant, yes, डॉक्टर साहब पैसे की कोई कमी नहीं, और क्या करेंगे, तो कर दीजिए रेफर, प्री स्क्रीन करिए, कैसे, histopathological or radiological evidence of UIP or NSIP, number one, FVC less than 80% predicted or DLCO less than 40% predicted, any oxygen requirement, any dyspnea or functional limitation attributable to lung diseases. Absolute contraindication for lung transplant are malignancy in last 2 years, advanced dysfunction of another organ, non-adherence to the treatment. ऐसा नहीं सीधे lung transplant, पहले आप जो treatment दे रहे हैं वो का adherence होना चाहिए, lack of social support, substance addiction, smoker अभी भी है तो मत करिए, age older than 65 years is a relative contraindication. So yes, KGMU has started the process of establishing the lung transplant, and I'm really honored, I'm privileged to the Vice Chancellor that he has kept me as a part of this committee. So prevention, yes, smoking, yes, occupational, yes, control, जो हिस्ट्री मिली थी, GRD also important. रात का खाना कितने बजे खाते हो? What is the most important treatment of GRD? Although gastroenterologists are there, I'm asking a silly question from my side. Most important thing to me is the raat ka khana rather than PPI. Early detection and monitoring, healthy lifestyle, avoidance of drug-induced ILD, management of autoimmune diseases, and patient education. So recent advances they have come, especially I would talk of stem cell and regenerative medicine. That is the new hope, and we are planning to have, because the regulation for stem cell therapy is still pending since 2 years. They are in now final shape, and we will start once they have come. And this is our publication on this issue. This is the first Indian book by any Indian author on this book. So this is my book, and most of our residents, they go through this. And you please do the social awareness also. So they are some by, this is the difference between TB and fibrosis. The public domain people also should know what's the difference. So I think in nutshell, that the ILD refers to a heterogeneous collection of more than 200 distinct lung disorders. The typical presentation of ILD is non-specific and may include vague pulmonary complaints such as dyspnea or exertion, cough, and abnormal radiograph. ILD is a restrictive disease most commonly misdiagnosed as pulmonary TB or asthma. So thank you very much for attention. Thank you, Chairperson, for allowing me 2-3 minutes more. Most of the time I don't cross the time, but this time I thought that this much of material is there, so I took 2-3 minutes.
Wonderful clinical discussion. Because we have the shortage of time, so I will allow only one question from the audience if you want to ask.
Yeah.
There is a talk of using 2 antifibrotics nowadays, Perferidion and Nintedanib. You said it with a lot of honeycomb.
I am against, sir.
You are against.
I am against.
Hello.
Second question is about this bird fancier disease. Fourth
Yeah.
में मुंबई में डाल रहे, गेहूं
जी,
में
जी।
डाल रहे, अहमदाबाद में डाल रहे, and this is aggravated.
देखिए आप अपने लॉन में छत पे दाना डाल रहे हैं और कबूतर चिड़िया कोई भी आके गौरैया अगर खाके और पानी पी के चली जा रही है तो कोई प्रॉब्लम नहीं। प्रॉब्लम क्या है कि 1000 कबूतर ऊपर लटके हुए हैं और आप भी वहां 1 घंटे 2 घंटे बिता रहे हैं। दैट इज द प्रॉब्लम। इस पे अभी मैंने दागी जान को एक बहुत डिटेल इंटरव्यू दिया है अभी 15-20 दिन पहले। जी जी, ऐसा हम अगर ऐसा स्टेटमेंट देंगे कि चिड़िया को दाना ही मत डालो तो गौरैया सब मर जाएंगे बेचारी गिलहरी और वो सब।
Yes, please.
सर हाँ माइक दीजिए।
Hello, I'm the odd one out here. I'm a cardiac surgeon, and I was involved in heart and lung transplantations,
Sir.
over a period of 6 years. So an excellent talk, Dr. Suryakant.
Thank you, sir.
I would just like to make a couple of quick and brief comments. That though the prognosis is typically very poor for ILDs, if the patients, and they are usually always prioritized is that they jump the lung transplantation list according to the lung allocation scores. And we have been having, 5-year survivals in the
Yes.
range of 70%. And in fact, as you said, hypersensitivity pneumonitis, which was very rare. We had a multi-center registry in the West, and because I spent close to 10 years there, it was only about just a shade over 100 patients of ILD over 25 years. Now you say hypersensitivity pneumonitis is so common here. I think it's just unfortunately a reflection of the poor air quality index
Yes.
in our country, the antigenic exposure causing repeated pneumonias. And the final thing is that hypersensitivity pneumonitis, if you were to take up patients for lung transplantations, they have an even better 5-year survival as compared to it. But once again, a lovely talk.
Thank you, sir. I agree, because until this ILD India registry published in 2017, Indian doctors or Indian chest physicians were also opinion that hypersensitivity pneumonitis is not too much high or too much prevalent. But because of the variety of occupations, variety of works, and poor hygiene, so many congested population, even workplace is congested, and that's why we are seeing more and more hypersensitivity pneumonitis. So that is, yeah, and you are right, sir, that in the Western world, hypersensitivity pneumonitis is not too much, because open environment, clean environment, neat environment, and personal hygiene also good.
Thank you, sir. Thank you very much, and thank you, my chairpersons.
Lovely talk.
Now I'm closing this session.
Thank you, sir. जी सर, जी सर. ये ले लो.
We'll now proceed with our next session, that is cardiology session. And for this, I would like to invite Dr. Shripad Khairnar as our moderator. Dr. Shripad has done his DM cardiology from PGIMER and Dr. RML Hospital, New Delhi. He's a former consultant cardiologist, Department of Cardiology, AIG Hospitals, Hyderabad. And he's currently running cardiology care unit at GASTRO LIVER HOSPITAL, Kanpur. He's independently performed more than 1,500 coronary angiographies and more than 200 coronary angioplasties. He's independently performed more than 50 pacemakers. Please welcome Dr. Shripad. I would now like to call our panelist, Dr. A.K. Trivedi, sir. He's the Chief Consultant and Director of Department of Cardiology, Regency Healthcare, Kanpur. He's practicing in Kanpur as interventional cardiologist for more than 46 years. He's worked as Senior Consultant at CMC Vellore. Please welcome Dr. Trivedi, sir. Our next panelist is Dr. Avdesh Sharma. He's Associate Professor at LPS Institute of Cardiology. He has more than 15 years experience in his field, and he did his DM cardiology from RML Hospital, New Delhi. Please welcome Dr. Avdesh. Our next panelist is Dr. Neeraj Varyani. He is presently working as Head of Department of Cardiology at GRS Hospital and Heart Center, Kanpur. He did his DM cardiology from CMC Ludhiana and has more than 10 years experience in the field of cardiology. Please welcome Dr. Neeraj. Our next panelist is Dr. Rao Sumen. He's working as Chief Cardiologist at Krishna Super Speciality Hospital, Kanpur. And he did his DM cardiology from Indira Gandhi Medical College, Shimla. Please welcome Dr. Rao Sumen. I would now invite our next panelist, Dr. Manoj M. Agni. He is Director CTVS Paris Hospital, Senior Consultant Cardiac and Transplant, and his area of expertise is coronary artery bypass grafting, valve repairs and replacements, aortic surgery, pediatric cardiac surgery. Please welcome Dr. Manoj. Now, Dr. Shripad will moderate the session.
I think we see the patients of hypertension day in and day out. Most of the time when we see the patients who require more than 3 or 4 drugs of antihypertensive, we can think of that the patients are of resistant hypertension. And I think we have the best speaker to talk on the topic. I will invite Dr. Nakul Sinha sir to talk on this topic. He is a chairman of Cardiology at Max Super Speciality Hospital, Lucknow.
Dr. Nakul is former professor and head cardiology SG PGI Lucknow, and he's past convener National Intervention Council CSI and Commonwealth Fellow Interventional Cardiology in UK. He has more than 156 research publications, editorials and book chapters to his credit, and principal investigator in 52 international multi-center trials. Please welcome Dr. Nakul.
Thank you. It's always very encouraging to see that on a Sunday afternoon and evening there is so much of patience and people are attentive. That's really very good, and I find whenever the meetings are held at Kanpur, this is the usual story. So there are only very few other places where you will find dedicated people listening to talks after talks. So thank you very much. Thank you, Dr. Mishra, wherever you are, for the wonderful program. Dr. Shripad also came personally to invite me, so I said I must go. We have so many luminaries on the dais, but during the discussion, I asked him that what would be your general audience. So I purposely have removed all the studies and this and that and exotic things, no. Kept it as simple as possible, because as you know that hypertension is one thing which has no symptoms but is the silent killer. So probably for the next 20 minutes, we'll try to see why this resistant hypertension and why hypertension is so important. Maybe you people will excuse me if I'm not showing the very latest exotic things, because they don't really sort of gel with the audience that we have here. At the outset of his talk, Dr. Surkan said that you breathe 25,000 times a day, but your heart beats around 6 to 7 times more than that. So, and you may remember, I mean, our old teachers used to tell us that you don't need to remind them. Your breathing and heartbeat, you don't need to remind them. They go on autonomously. So, the importance is that both the lungs and heart are working so hard to keep you healthy, to keep you functional, and to keep you living. I think, what do we call? Cardiorespiratory arrest. Kuch bhi ho, wo thappa wahi lagta hai. But, so that is the importance of cardiac and respiratory. Brain को कोई नहीं कहता कि brain dead हो गया. वैसे तो बहुत से लोग brain dead वैसे ही घूम रहे हैं. Anyway, so this is the pointer. Yeah. So this is from the time of World War II. All of the 3 great people who brought the end to the World War II unfortunately died from complication of hypertension, because no modern medicines were available then. Be it Churchill, Roosevelt or Stalin, none was on medical therapy, whatever was available. So, I mean, because the knowledge has not evolved and it is asymptomatic. This is a World Health Organization report from 2023. Now they have come out with this global hypertension crisis. It's not that it's something to be taken note of. No, it's a crisis. Incidence is increasing, detection is poor, and control is even poorer. On top of that, even if you give medicines, half of your patients will stop them beforehand. This figure I have especially kept because this is for the females, or better halves of the world. Yesterday was the Women's Day, so that is why I put it here. This is 2019 figure that out of the total hypertensives, which are quite a lot, all over the world, 41% will not be diagnosed. They will never come to know that they are having hypertension. Out of those who are at least diagnosed or told to have hypertension, less than half will be treated. Others will either say, well, we are not going to take treatment, cannot afford, whatever it is. 12% are diagnosed but is still not treated. And out of them, treated but not controlled is again a significant number. So you can see roughly only 1 in 4 patient of hypertension who has been diagnosed, they will be properly treated. Now every 3 years we have recommendations of hypertension authorities which are bringing down the blood pressure level, just like diabetes. And it seems unrealistic, but the data is there to support it. So any age, 120, 80 is the normal. In our very old textbooks, it was written that you can have a formula of age plus 100 for this systolic norm. So the awareness has to be there, the will has to be there, and the methodology has to be there to pass on the benefit to your patient. Why is hypertension so important? All the vital organs are going to get damaged at one stage or other if you don't treat it. Renal, cardiac, brain, and even by way of diabetes, all the other liver and pancreas, etc. And mind you, these are not, I would say, benign things which are going to continue for some time. They can lead to death very fast, sudden cardiac death, hemorrhagic stroke. They can incapacitate you. I mean, when we were asked to pick up super speciality, I was interested in neurology, and I was supposed to be good at that, but then I saw that most of the patients don't have any benefit. So I said, no, I'll drop neurology. So we know there are now advances in treatment, but it is very incapacitating. It's very depressing, frustrating to see stroke patients just dragging themselves around. Hypertension, by any study, any means, any society, WHO papers, is the leading cause of cardiovascular disease and death. And cardiovascular disease are unfortunately the #1 killer for the last 14 years. They are not going to come down. So, I mean, though we are not going to discuss how to detect and how to diagnose hypertension, but what we should understand that in any gathering, there are going to be few people who have severe hypertension which may or may not have been diagnosed, and possibly 1 or 2 resistant hypertension. Because they just don't bother, because it's asymptomatic. Only when the hatchet strikes, then they have a problem. Is the situation different in India? We always say Indians are different. I don't know. Probably it's worse. By all the data collected, all the figures in the public domain, the hypertension control rate are abysmal. I am sorry to say, I even come across physicians, I come across medical professionals, and even one of my friend cardiac surgeon, who were not controlling their blood pressure. So you have to really tell them that please, please, come on, this is something that can be done. There have been studies all throughout the world where they have seen that if you prescribe more than 2 pills or more than 1 pill, the sort of tolerance or rather the adherence to the medication goes down. They will not take multiple pills. That is the concept why polypill is now so popular. Polypill for secondary prevention of MI, of heart failure. So polypill, 3 or 4 drugs in fixed dosage. That is one, I would say, a great advancement, but it needs to be more popularized. This chart should be shown to all the skeptics. They say, I'm not having any problem, all my tests are normal, why should I take blood pressure medication? So if you treat your blood pressure, if you bring it down by 5 millimeters of mercury, this is the projected benefit from various meta-studies, meta-analysis. And if you can bring it down by 10 millimeter, this is the benefit. So the data is unequivocal, very straight, very definite, and very promising. Why resistant hypertension? So first of all, we need to understand what exactly is the definition here. This definition has been around for many, many years, and even now this is the correct definition. When the BP goal is not being achieved by 3 drug regimen, one of which has to be a diuretic. But please look at the fine print. It has to be full doses. We are using very small doses mainly and say that, no, my blood pressure is not responding. No, use the full doses. Beta blockers full doses goes up to 200 milligram. Amlodipine full dose can go up to 30 milligram, 40 milligram. Nifedipine, it can go up to 150 milligram. Anyway, typically a long-acting calcium blocker, a ACE or an ARB, and a diuretic given at maximal tolerated doses. Now this will also be true for patients who are taking more than 3 drugs to control their blood pressure. That would be called the control resistant hypertension. But wait a minute, there may be so many people who may say that, well, we are taking 3 drugs, it's not being controlled. So that is a refractory hypertension. This is one step lower. Here you need to exclude out secondary causes and find out why these drugs are not acting. There may be problems. Drug interactions are rampant. In fact, I can't remember. Even if you have a chart, it takes a long time to find out where are the drug interactions. Addictive substances, even a small amount of tobacco, smoking, etc., antidepressants, nasal drops, so many things which are just over the counter, available anywhere. But yes, obesity, sleep apnea, ethanol intake, which is more than the usual permitted limit, anxiety and hyperventilation, these also are very common. So why I'm just putting these things without going into detail is you need to understand the 360-degree approach, which has to be there whenever you are trying to investigate a patient of hypertension. As Surkan said, a proper history and ticking of things is extremely important. Otherwise, you will miss it. Renovascular, adrenal, renal disease, they are there in less than 5% of patients, but those are old figures. I would say the secondary hypertension is now increasing, more renal disease, etc. These are the common drugs which can lead to or rather promote the resistant hypertension. You can see all these are very, very commonly in use. More than half of us will be taking one or the other. Pseudo-resistance, now that's also important. White coat hypertension, as soon as the patient walks in, the blood pressure will go up. And mind you, it's very difficult to make them calm down, sit for 5-10 minutes and time consuming. So nobody is going to do that. Quite frequently I ask them to show me the wrappers so that a pill count, I instructed my paramedical staff, get a DSA done. That's the best, simplest and very DSA done. That's the best, simplest and very accurate thing. Very accurate thing. And if it's a severe renal artery, in SGPGI we had tons, we had published series of hundreds and